Very good morning. Now we'll move on to the very important session, insulin workshop. You all know insulin is the only drug which will have no failure because we can increase to the maximum extent till we get the failure. Now we are going to focus on postprandial hyperglycemia because this is the one which is causing most of the endothelial dysfunction. And in a diabetes, to diagnose first diabetes, it is the postprandial which is very important. And to know about this, we have our renowned speaker, Dr. Shashank Joshi, who is MD Triple FRC and many other degrees. He is the past chair International IDF Southeast Asia, President Indian Thyroid Society, past Dean Indian College of Physicians, past President API, Emeritus Editor JAPI, President Indian Academy of Diabetes, past President Endocrine Society, past President and Patron RSSDI, Founder Vice President PCO Society, and President AIAR, that is All India Association of Advancement for Research in Obesity, and past Chair Indian American Association of Clinical Endocrinology, and many more. And is above all the encyclopedia of diabetes and endocrinology. Let us hear from him about the postprandial control. Over to you, sir.
Thank you so much, Bhavatharini. And as you rightly said, this is an insulin workshop, so idea is to learn. And my brief today, this is a sponsored talk by an innovator called Eli Lilly, but which is licensed to Cipla. So it's sponsored by Cipla. And the idea is that we know that in India, we eat a lot of prandial glucose. In fact, I just had my breakfast at a wonderful venue. And let me see, you can clearly see there is a spike, which all of us have after breakfast. So I'm not a diabetic, but as Indians, you can see right now my sugar is 135, on the latest. So we all have a spike, and Indians eat fast, so they get a faster spike. Particularly in the first 30 minutes and 60 minutes and 90 minutes and 120 minutes. So controlling glucose in the first 1 hour, 2 hour and 3 hours is very crucial. And IDF came out with a guidance on 1 hour prandial glucose. And we are today going to discuss the role of Ultra-Rapid Lispro. So that was the talk. And this is a Cipla talk, as I said, because they make a compound called Limgio, licensed from Eli Lilly and Company. So fundamentally in the next 12 minutes, I will just reiterate the importance of prandial glucose, its impact, its risk factors, then this so-called mealtime gap and its correlation with prandial glucose. And then we have clear-cut gaps in prandial glucose management. We have prandial insulins, and this is a ultra-rapid acting Lispro insulin. What's the evidence? How it allows us mealtime flexibility, and what is the therapeutic paradigm for satisfaction for these new rapid acting insulins, and maybe a conclusion slide there after that. So prandial glucose, we know the first and the second phase of insulin secretion. We know that in type 2 diabetes, one of the earliest symptoms is the loss of the first phase. And that's the pivot for prandial glucose excursion. But we know A1C doesn't cover all this very well. It doesn't take in account of glycemic variability, but because of CGM, we are able to pick up the glycemic variability better. And fundamentally, we know that A1C, particularly in our country or China, correlates very well with early post-lunch, late post-lunch glucose levels, but less with fasting glucose. So when you look at prandial glucose as an independent risk factor, this is a meta-analysis which looked at the impact of PP on A1C. In the Western world, they are very fasting-centric. If you see Louis Monnier, who's a physiologist from France, he always said, fix the fasting first, particularly if the A1C is about 8.5 and 9. But in our geography, if our glucose is not well controlled prandially, we get retinopathy, cardiovascular events, all-cause mortality, and even cognitive dysfunction. And there's a lot of expert consensus opinion from the Indian experts which clearly say that in our population, it really matters because we eat a lot of carb-rich foods, and we did a STAR study to document the same. So clearly we recognize that as healthy individuals, after a meal, and I just showed you my own glucose, which is now 135, and you can see it here, okay, we all get a rapid pancreatic insulin release. The faster you eat, the faster the glucose will grow up. And we also know that our intestines make intestinal peptides, which are nothing but glucose-dependent insulinotropic peptides or polypeptides or glucagon-like peptides, and they have been exploited pharmaceutically. But basically in diabetics, we recognize the prandial insulin is not sufficient to drop that prandial glucose. The first phase in the first 10 minutes of insulin release is a physiological beta cell response, followed by a protracted, prolonged, steady, long-standing second phase. So again, insulin release has two phases, first phase and second phase. First phase is lost, first is the 10 minutes. And that rapid early first phase insulin secretion is what people are trying to mimic, because that is the primary determinant or the chief determinant of prandial glucose. And once that is lost, you typically are going to ensue type 2 diabetes. So as I told you, the prandial 1 hour glucose typically ranges between 70 and 100, rarely exceeds 140. I am still at 135, so I am 5 points away from that. So maybe I may have pre-IGT. And then it returns to pre-prandial level after 2 to 3 hours. So clearly in CGM studies, they show the mean peak time after breakfast is 72 minutes. And it reaches it less than 90 minutes in 80%. And IDF, as I told you, had this 1 hour glucose loading guideline. A concept in prandial glucose now called mealtime gap has become more popular. As I told you, the mealtime bolus is designed mainly to predict the prandial glucose insulin and try to get better glycemic control. And therefore, it is very important that the asynchrony between the glucose absorption after meals and the delayed insulin response is matched correctly, and fundamentally adjust the prandial insulin timing relative to meals to meet that insulin requirement. And the rapid acting insulins are absorbed too slowly to get that optimal glucose control, because most of them we administer them around 15 to 20 minutes before meals. So when we look at the injection to mealtime interval in real life study, we clearly recognize that the pre-meal insulin negatively affects lifestyle. People don't eat appropriately, sometimes forget to take their insulin, and the pre-meal insulin responses add a burden and negatively impact emotionality. So when we look at a real world setting, some people take it just before meals, some during meals, some after meals, some before meals. So never it is correctly administered at the correct time. That's the analysis of this. So clearly there is a gap between prandial glucose monitoring and the metrics of glucose variability. Has a lot of inter-individual variations with temporal profile. The single point cutoffs are not easy. There's a lack of consistent, effective, rigorous defined measures for prandial glucose. A lot of data points are missed, and its net result is glycemic burden and a sustained hyperglycemia. And therefore in intervention trials, we often get prandial glucose as a non-rigorous surrogate measure. So those are the gaps. And that is the need of having newer insulins, analog insulins, mainly to correct that gap. Because the onset of action should match the carb absorption, and the PK/PD doesn't mimic the physiological post-meal insulin secretion. And therefore, when we look at gradation of the modern insulins, we have rapid-acting insulins, which have a little lesser hypoglycemia and greater mealtime flexibility, grade A. We have ultra-fast-acting insulins, which are little better mimics than the rapid-acting insulins. And then we have ultra-fast-acting insulins, better suited for people with Indian glucose excursions. So we are currently trying to, and that's the reason also you will have inhaled insulin coming up very soon, okay, from the same people who are making these insulins also, clearly to address and plug that gap of new prandial glucose. So when you are looking at prandial reduction, the entire postprandial period, at the beginning of the close to the meal, we can clearly see we want to mimic that physiology and improve the timing range. And that is the birth of Ultra-Rapid Lispro. And in the last 5-7 minutes, this is a Ultra-Rapid Lispro. It's a novel formulation. It has two enablers. There are two substances or excipients called treprostinil and citrate, and these accelerate the absorption of Lispro from the injection site. What does the citrate do? it increases the local vascular permeability. What does treprostinil do? It's a prostacyclin analog. We all know prostacyclins. It's a prostacyclin analog which causes local vasodilation without causing systemic vasodilation. So again, we are enhancing, these are enablers or enhancers for acceleration of absorption for a rapid action. Citrate and treprostinil, a prostacyclin analog. And therefore, the subacute tissue space, which you are exploiting as a pharmaceutical reservoir for absorption of insulin from a hexamer form to a monomer form, clearly you can see in the ultra-rapid Lispro, the citrate and the treprostinil is enhancing the hexamer to monomer time. It is shortening that time due to increased local vascular permeability and local vasodilation. Those are the two crucial excipients which are making the difference. And therefore the peak of Lumjo is fundamentally trying to mimic the physiological peak. It's near there. And if you see from a pharmacokinetic standpoint, the onset of action is 20 minutes. It's 11 minutes faster than the conventional Lispro. During the first 30 minutes post-dose, there is a 3-fold glucose lowering impact. So it is hitting hard where it matters the most. And therefore there is maximal glucose lowering in the first 1 to 3 hours. And it tails off also very rapidly. So there is no delayed peak to cause a hypo. So it's clearly seeing, and this is all clamp data, both in type 1 and type 2 population. And therefore you can see the earlier 50% of Tmax is achieved earlier. It is 5.9 minutes faster than Fiasp, 12.5 minutes faster than Humalog, and 13.9 minutes faster than NovoRapid. So clearly you can see a incremental advantage of Lumjo, which is clearly seen. And when you look at the prandial glucose profiles in the same subset, you can clearly see a distinct advantage. This is a study done in basal bolus regimens with type 2 diabetic population called Pronto type 2 diabetes, where they have head-to-head compared ultra-rapid Lispro with Lispro alone. And you can see in this study, again, ultra-rapid Lispro was non-inferior to Lispro for change in A1C, but the advantage is that the prandial excursions were significantly better in the ultra-rapid Lispro compared to the Lispro throughout the entire spectrum of area under the curve, 15 minutes, 30 minutes, 60 minutes, 120 minutes, 180 minutes, 240 minutes. The entire state from 30 minutes to 4 hours after a meal consumption without any impact on hypoglycemia. In fact, there is no substantial difference in the rates of severe documented or nocturnal hypoglycemia, and a significantly higher post-meal hypoglycemia was seen in the other group. So from an adverse event standpoint, it clearly stands out. So clearly we recognize that ultra-rapid acting Lispro is non-inferior to Lispro in A1C, has a lower prandial excursion throughout the prandial state between 30 to 4 hours. There is no significantly difference between clinical relevant categories of hypoglycemia, including documented severe and nocturnal hypoglycemia, and the safety profile is similar. The phase 3 studies, again in type 1 population, again you can see excellent data, better prandial control in the type 1 population, similar incidence of hypoglycemia, excellent safety data, again documenting that even in the type 1 population, there is an advantage. And here the advantage is not 30 and 4 hours, it is 15 minutes and 4 hours without any adverse impact. So clearly this is data to show that there is mealtime flexibility with Lumjo or the ultra-rapid Lispro as a mealtime insulin subcutaneously, and it should be administered 0 to 2 minutes before the start of the meal. In fact, in my clinical practice, sometimes it's administered even after food, particularly in the type 1 population, when they are not sure what they are going to consume. In the geriatric population or in the type 1 population, many a times people are not sure what they are going to eat, and therefore we don't know the amount of carb load they will have, and sometimes it may be easier. You can even go to administer it 20 minutes after starting the meal. So that's the advantage of this insulin. And when we look at a Japanese data, which was a therapy related satisfaction, which was a survey of type 1 and type 2 population done during COVID times, because in COVID times, a lot of web surveys happened, and this was post-COVID. You could see that a larger population felt very, very comfortable to start insulin at the meal, in front of them, or after the meal. And that's completely very clear. And there was a better satisfaction rate in that population in a Japanese study. So finally, my last take-home points in my last minute is that Ultra-Rapid Lispro is 10 minutes faster action, has 3-fold greater insulin action. The duration of action is 44 minutes shorter. The tail is not there. It closely matches the early physiological control in healthy subjects. So it's correcting that first phase. And in the 1 hour, 2 hour prandial glucose excursions, it clearly is superior to all other insulins. It gives you a convenience advantage. It has global data, and it ensures that there is no hypoglycemia. And therefore, clearly it's indicated for diabetes in adults. It's available in India for more than a year now, and we clearly see a substantial advantage, and you know that it can be used for a prolonged period of time. Thank you so much for a patient hearing.
Thank you. Thank you, sir. As you rightly said, that it can be given even after food. That is, in many sick patients, we do not know whether they will take food or not. So you can wait for them to take food, and even after that you can use it. Now I pass on to my co-chair.
So any questions from the audience? I think we'll have the questions towards the end.